In this video, we'll discuss about oral leukoplakia. It is a precancerous condition that causes white or gray patches inside the mouth. So it causes white or gray patches inside the mouth. Leukoplakia is a clinical presentation rather than a disease process. The patches are hyperplastic lesion on of the oral squamous epithelium, with some of the cases tending to malignancy, ultimately giving rise to oral squamous cell carcinoma. These white patches, unlike oral candidiasis, cannot be scraped off easily. So the etiology of oral leukoplakia is unknown. It is generally thought of as the body benign reactive response to irritation to oral tissue. Some predisposing factor most frequently blamed for the development of idiopathic leukoplakia include tobacco use, which is considered to have a strong association with oral leukoplakia, alcohol consumption, chronic irritation from dentures, malocclusion that causes chronic biting of the cheek and tongue candidiasis, vitamin deficiency, endocrine disturbance, and possibly associated with human papilloma virus 16 and 18. The global prevalence of leukoplakia is 2.6%, with the malignancy conversion rate ranging from 0.1 to 17.5%. Various studies have shown that up to 20% of lesions can become malignant in the next 10 years. 10% malignant in the next 10 years. 20% lesions become malignant in the next 10 years. It is more common in men than women. Elderly population in their 50th and to 70th decades of life, it is mainly affected. Approximately 80% of people are older than 40 years of age. Clinically, individuals with oral leukoplakia are asymptomatic. It can appear anywhere in that oral cavity and falls into one of the following two main categories: homogeneous and non-homogeneous leukoplakia, which account for 95% of all cases, and the non-homogeneous leukoplakia, the much less frequent lesion. In homogeneous leukoplakia, as the name suggests, uniform white plaque are present and usually have low free malignant potential, and the lesions are flat, sometimes might be sprinkled. Non-homogeneous leukoplakia is far more serious than the homogeneous type, and the name suggests it include mixed component of red and white and has several subtypes. These are speckled or nodular leukoplasia. Has white flecks and fine nodules, often areatous base. Since it has red and white intermixed lesion, it is known as erythroleukoplakia. Regard as a combination of or a transition between leukoplakia and erythroplakia. which is nothing but red lesion. The Leukocyte type has sharp or blunt like projection. A special high-risk form of leukoplakia is proliferative verrucous leukoplakia, characterized by the development of multiple slowly spreading and chaotic plaque with a rough surface projection. So, special risk form of leukoplakia, proliferative verrucous leukoplakia. The lesion in the beginning are indistinguishable from verrucous leukoplakia, but they later usually developed dysplasia and transform into full-fledged squamous cell carcinoma. Proliferative verrucous leukoplakia is an unusual variant of leukoplakia and has a strong female predilection with 1:4 male to female ratio, and surprisingly, unlike other variant, it has minimal association with tobacco. The following criteria demonstrate high tendency of leukoplakia to change to malignancy. The verrucous type is considered to have a high risk of malignancy. Verrucous type is high risk of malignancy. Then erosion or ulceration within the lesion are highly suggestive of malignancy. Then presence of a nodule indicate malignant potential. A hard lesion in its periphery is predictive of malignant change. A hard lesion in its periphery is prediction of malignancy change, and oral leukoplakia of that anterior floor of the mouth and under surface of the tongue is strongly associated with malignant potential. In all cases, the relative risk of malignant potential is confirmed by presence of epithelial dysplasia through histological examination and considered a gold standard for assessment of malignancy. Treatment: surgical extraction of that lesion may be considered to treat leukoplakia. Then cryotherapy, ablations, carbon dioxide ablations also used because of that unpredictable behavior of dysplastic lesion, and immediate biopsy and any suggestive area with the change in appearance should be performed. Smoking and alcohol consumption cessation is necessary since it has a strong association with tobacco use. The patient should be followed up every 6 months for 3 to 5 years after treatment. The area heal rapidly after biopsy and healthy mucosa is left behind and however unsuddenly remain regarding the risk of invasive carcinoma subsequently arising inside previously treated. That's why follow-up is indicated. So in this video discussed leukoplakia. Thanks for watching.